Hey guys! Okay, so I'm starting to lose my voice, so bear with me. This video is on gastric cancer, and that is on page 1115 in our book, chapter 55. This is also a long section, so bear with me. Some of it is repetitive from the other two diseases, so we'll just kind of run with it. But most gastric cancers are going to be adenocarcinomas. And the problem with gastric cancer is that it's pretty insidious. It's not going to really have any symptoms until the disease has progressed pretty far. So it's usually advanced by the time patient notices any symptoms. It usually starts in the glands of the stomach mucosa. And I had mentioned earlier in another video about the atrophic gastritis being precancerous. So that's something that can be a big issue here. Basically, what happens with that is with the atrophic gastritis, the bacteria multiplies, and then the infection leads to a mucosa-associated lymphoid tissue lymphoma, or the MALT lymphoma. And gastric ulcers spread into the regional lymphatics. So the problem with that is that those carry tumor deposits to other lymph nodes. So this cancer can metastasize pretty easily, and also it can metastasize to neighboring organs, so the liver, pancreas, or colon. And the 5-year survival rate's pretty poor because it's very asymptomatic. The etiology or genetics of this is that usually we're going to have it come from the H. pylori again. You're going to see pernicious anemia, gastric polyps, chronic atrophic gastritis, and achlorohydria, or the absence of the secretion of hydrochloric acid in the stomach. Any patients with those issues are going to be 2 to 3 times more likely to get gastric cancer. So we need to assess those patients really well. Risks for gastric cancer are going to be an intake of a large amount of pickled foods, nitrates, processed foods, smoked foods, high sodium diet, people who don't eat a lot of produce, and also if they've had gastric surgery or Barrett's esophagus. Remember we talked about Barrett's esophagus is that columnar epithelium that builds up in the esophagus with GERD. So we discussed that in another video. But educate your patients on what to look for if they have those issues, or if they need to change their diet. It is definitely more common in men, generally people over the age of 50. Most people who are diagnosed tend to be between the ages of 60 and 80 years old. And regionally, there's a higher incidence of gastric cancer in Japan, China, Southern and Eastern Europe, and then also in South and Central America. So, also, it's going to be more common in Hispanic Americans, African Americans, and Asian Pacific Islanders. They'll be at higher risk. And then, just kind of keep an eye on those groups. And then the average age of diagnosis from our book is 69 years old. So again, these are going to be your usually elderly patients. We want to teach patients which foods to avoid, especially if they have gastritis, and then also treat H. pylori if they have it. So I actually had no idea that H. pylori could be this serious. So good to know. And then for our assessment, we want to ask them a lot of questions about their diet. if they have previous infections, and then also, again, history of gastric surgery or polyps, and also any relatives with gastric cancer. We have a chart in our book. It is chart 55-6, and it's going to give you symptoms of early gastric cancer versus advanced gastric cancer. So early symptoms are going to be fairly mild, it looks like. So indigestion, abdominal discomfort. Usually that discomfort is taken care of with antacids, which is why another reason why this is not diagnosed early, because patients can take OTC meds and feel better and think that the problem is taken care of when it's not. Also, a feeling of fullness, epigastric back pain or retrosternal pain. I mean, who doesn't have back pain that's elderly? So it would be really easy to ignore these symptoms. If it's advanced gastric cancer, we're going to see more nausea, vomiting, obstructive symptoms, iron deficiency, a palpable mass, also enlarged lymph nodes, weight loss, fatigue, and weakness. For the physical assessment, when we actually put our hands on them, we could find nothing. So that's another reason why it's not diagnosed. Sometimes you can't feel the mass that's in there. If you do feel an epigastric mass, then you might feel a hepatomegaly. When we feel that right below their rib cage. If you can feel that enlarged liver, then it's usually metastasized at that point. Usually it's going to be hard and just enlarged. Lymph nodes in the left supraclavicular chain, left axilla or umbilicus. So that's again why our lymph node, when we do our physical assessment, really feel for those lymph nodes. Let's see. Check the epigastric lymph nodes. And then also we can look for occult blood. Again, low hematocrit, low hemoglobin. Let's see. Abnormal liver tests. It's usually diagnosed with an EGD with biopsy or ultrasound. They can also have a CT, PET scan, or MRI of the chest, abdomen, and pelvis to see how far it's progressed. And then as far as interventions, with gastric cancer, they can do chemo and radiation. If they do radiation and it's like a stage 3 or 4, usually that's just palliative care at that point. They can also, if they do chemo, there are 2 drugs that were mentioned in our book. One was the cisplatin, and the other one is the epirubicin. We need to teach them about bone marrow suppression with those drugs, and then also they're going to have symptoms of nausea and vomiting, so we want to give them antiemetics. If they have radiation and or surgery, then they're going to more likely than not experience fatigue, skin breakdown, anorexia, nausea, vomiting, and diarrhea. For the surgery, resection is the preferred method to treat this. So they can have a subtotal gastrectomy or a laparoscopic surgery. If it's in the early stages, they can do laparoscopic. If it's in later stages, then the gastrectomy is probably going to be an open surgery so that they can see where else the tumors have spread. So they can also do adjuvant chemo and radiation with the surgery. A lot of times they'll do those together. So if it has metastasized to lymph nodes, or neighboring organs, then usually the surgery is not recommended. And again, that's why I'm saying if they have radiation, it's usually going to be palliative. For the patients who have the open gastrectomy, then they are going to have an NG tube. If they have a laparoscopic gastrectomy, then they'll probably not have an NG tube. And that's according to our book. So just an FYI there. We want to do nutrition therapy before they have surgery to correct for any malnutrition. That's basically going to be so that they're strong enough to get through the surgery. And then they can do TPN, total parenteral nutrition. So depending on how bad it is. And then for, let's see, post-op instructions, we want to prevent atelectasis, keep an eye on their lungs, and then we want to watch for paralytic ileus, wound infections, and peritonitis. Document and report any of those to the surgeon immediately. That would be a great static question. So, again, paralytic ileus, atelectasis, wound infection, or peritonitis. Report those immediately. So we want to also auscultate their lungs, look for any crackles or diminished breath sounds, monitor for a return of bowel sounds after these surgeries, and then make sure we teach them to do their pulmonary exercises. So use their spirometer, and then also ambulate them day of surgery or the day after, whatever the doctor orders, but that way we can prevent any DVTs. Also inspect the operative site every 8 to 12 hours for redness, swelling, or drainage. And then we want to keep the head of their bed elevated too. We're also going to watch for a clogged NG tube because the doctor will probably have to order irrigation or replace it. So, and then for symptoms of a clogged NG tube, we're going to look for acute gastric dilation, so the feeling of fullness. They might get hiccups, to be tachycardic, or have hypotension. So, watch out for that. Also, another thing we need to look for is dumping syndrome. So, with dumping syndrome, this is going to come up again later when we talk about some other stuff, like there's a problem with esophageal cancer, and then a couple of other things which we'll get to down the road. But basically, it's rapid emptying of food into the small intestine within 30 minutes of eating, and the symptoms of dumping syndrome are vertigo, tachycardia, syncope, sweating, pallor, palpitations, and a desire to lay down. So we want to report that to the surgeon and then actually have the patient lay down. So for once they can do something they want to. And then there's also late dumping. So late dumping syndrome is going to be later down the road than the 30 minutes. It can be 90 minutes to 3 hours after they eat. It's usually caused by an excess amount of insulin. So those patients are going to be dizzy, lightheaded. They'll also have palpitations, diaphoresis, and confusion. So the management of dumping syndrome, we talked about in class a little bit. It's on table 55-3. And there's a special diet for them, which you guys can look over that. And then general principles is that we want to decrease the amount of food that they're taking in at one time. So no liquids with meals, because that can lead to diarrhea. And then also they need to eat a high protein, high fat, low to moderate carb diet. And then we can, in extreme cases, we can give them medications to slow down the digestion. So they should eat low roughage and no milk, sweets, or sugars. And then also there's like an actual list of foods in our book. So check that out. But general principles, small meals frequently throughout the day. And then for another complication is alkaline reflux gastropathy. It's a complication when the pylorus is removed or bypassed. There's a photo of that in our book too. But basically, it puts regurgitated bile into the stomach. And patients with that are going to have early satiety, so they're going to feel full faster than they should. And then also abdominal discomfort and vomiting. Let's see here. Also, another complication, I guess, is the delayed gastric emptying. So it's present after gastric surgery for about a week. So if it lasts longer than that, then that's really abnormal. So the treatment is going to be a NG suction and then maintenance of fluid and electrolyte levels. So we want to balance that out and also make sure they're getting proper nutrition. And then that delayed gastric emptying should get better as they recover from the surgery. We want to monitor a couple of things with these patients too. In particular, we want to monitor their B12 levels, folic acid, iron, calcium, vitamin D, also their CBC for megablastic anemia. And if they have that, they're going to have a lower RBC and a lower WBC counts. So reoccurrence of gastric cancer is very common, so they need to take their follow-up care seriously, and then we need to teach them what they need to do for follow-up care. And then also psychosocial issues we need to address are their ability to cope, and then the possibility of end-of-life care. So especially if they're stage 3 or 4, we need to educate them on hospice and generally just find out if they, want to talk to a clergy member, whoever their, therapist, whoever we think is going to help them. So for teaching with these patients, we want to teach them wound care, nutrition. So this is a strong relationship with their registered dietitian, this area. So collaborate with them. And then the side effects of chemo and radiation if they end up having that. So depending on, what they want to do. My grandmother actually passed from gastric cancer. So for her, by the time we found it, it was stage 4. And she opted not to have chemo, radiation, or surgery and just went, lived her life until she needed hospice care, at which point we were able to get that for her. But she was in her late 70s. So again, very common in elderly patients. Difficult to treat if it is advanced. So if anybody has questions about that, let me know. Let's take really good care of our patients and pass our exams, guys. So I will continue with the next chapter shortly here, and then we'll see if we can't get in all the chapters before the exam on the 10th. So thanks, guys, and take care of yourselves. Bye.